We have today with us an expert in minimally invasive valve surgery, Dr. Mattia Glauber. Mattia, can you introduce yourself to our viewers?
So I grew up professionally first in Germany, then in Bergamo and Milan with Professor Parenzan that you remember very well. After 6 years, I moved to Massa in Tuscany, where since the past 15 years I was leading the cardiothoracic department, and since 6 months I'm now here in Milan.
I've looked at your submission, the last submission in Multimedia Manual. You made several Perceval S sutureless aortic valve prosthesis implantation via a right anterior minithoracotomy. So, minimally invasive approach to valve surgery is becoming very popular. There are obvious advantages: shorter hospital stay, shorter ICU stay. What is overall proportion of aortic valve implants in your center done by such approach, and what proportion is done by a regular stenotomy?
Since the introduction of sutureless technology, I started in 2011 looking with a big interest to this technology, because with my previous experience, even with a big clinical advantage, the problem was always related to a prolonged cardiopulmonary bypass time and cross-clamping time. And since we have this technology, we shorten this, and actually it's much easier. It's a standardized procedure. It's reproducible even in conventional skills, so that actually 90% of the procedures are done through a right thoracotomy.
The field of the aortic valve replacement now is in movement due to various catheter technologies, transfemoral, transapical, transaortic. How does this type of operation stand versus transfemoral catheter?
Transcatheter therapies grow up even in terms of number with a great interest driven by the companies in this particular interesting field. Thinking that it has to be addressed to very high-risk patients or inoperable patients. Actually, the standard for aortic valve replacement is still the removal of the native valve, which is the most physiological way to treat this disease. Minimal invasive aortic valve replacement is probably the real alternative. We cannot still perform this procedure with a full sternotomy, since we have minimal invasive approaches.
How long have you been doing this Perceval procedure? What's the longest follow-up that you have?
My follow-up is 3 years now. Just yesterday I presented the overall experience of 390 patients performed with Perceval implants.
And no early deterioration?
Actually, the longest follow-up is over 7 years without any deterioration of the valve.
The Sorin Perceval is, when I look at the prosthesis, it's really a hybrid valve. It is similar to TAVI, to transcatheter procedure, but it's surgically implanted. What do you consider the main advantage versus transcatheter use?
As I told before, we are removing the native valve. We are decalcifying the annulus. We can really clean the annulus and to respect the left ventricular outflow tract with a very performant, hemodynamically performant valve.
The annular decalcification, it's obvious the biggest advantage of these valves. I never could understand how the transcatheter valves function so well, but they do function. Have you looked at some other factors differentiating between transcatheter and Perceval, for instance, paravalvular leakage, hemolysis, and similar?
In terms of the hemolysis, there is no difference. In terms of paravalvular leak, yes. With the first generation Edwards valve, we analyzed in my experience in Massa Hospital with a propensity score matched study. 38 patients after propensity out of around 80 per each group, and what we found was a higher 40% increase of paravalvular leak in the TAVI group and a greater survival with the surgical group.
Yeah, well, it's logical because you remove the calcium.
Yes.
Did you also realize that you could put a bigger size of the prosthesis in when you decalcify the annulus versus catheter techniques?
The way of sizing is totally different. With TAVIs, we are obviously sizing with a CT scan and by echo, and it's a preoperative planning. With surgical, we usually size intraoperatively. And when we tried to compare the CT scan sizing before for the planning of the procedure, we observed that only in 80% of the cases there was a correspondence. In the remaining 20, we were able to implant a greater valve.
When you are doing this procedure, what are your present cross-clamp times now and cardiopulmonary bypass times?
It's quite different because I'm not a fast surgeon because I like to teach every time. Each procedure is a moment in which I have to share with some other. And in any case, comparing the sutured valve through a right thoracotomy, I was able to reduce the cross-clamping time of about 50%. Actually, the cross-clamping time with the sutureless is similar to the sutured valve implanted through a full sternotomy. And it's around 35-40 minutes of cross-clamping time.
How much is this procedure spreading? Do you know the number of centers which are switching to these sutureless valves? Information from the company, we cannot name it.
There is a great interest. The numbers of implants are growing in a consistent way. There is even a great interest in looking to the right thoracotomy as a next step of the partial sternotomy. And I think that technology can allow this improvement because even in my experience, right thoracotomy is superior to partial sternotomy. It's obviously a more demanding procedure in terms of skill. It's not a procedure for everybody. Are there any
special contraindications like pulmonary function, position of the aorta? Do you look at the CT scan if the aorta is more to the left, the size of the aorta?
With the actual imaging technique, we can really predict the complexity of the procedures that we are going to perform. The position of the aorta in respect to the sternum, the length of the aorta is important, the orientation of the valve towards the right thoracotomy, the amount of calcium. These are all important information that we need to know not only for a minimal invasive procedure, but it's also important for conventional surgery.
And do you have a fixed contraindication for this procedure? We'll say no, this patient needs a stenotomy.
If really fixed contraindication is a right wall chest severe adhesion and a reduced surgery in which we have patent grafts on the ascending aorta, or when the removal of the prosthesis in case of valve degeneration can be expected to be complex.
And emphysema and COPD is not a contraindication to the...
Not obviously. If we have an important emphysema and we risk to damage the lung, it's better to keep the pleura closed and to stay median.
Some of these thoracotomy procedures require quite an amount of post-operative analgetics. Did you check this? Are you also performing an intercostal nerve blockade?
No. The pitfall for this is to don't spread immediately and too much the ribs while you are performing the procedure. So to go step by step in retraction of the ribs. And once you proceed, first when you open the thorax, and when you start to open the pericardium and you spread a little bit more. When you need to go to the ascending aorta, you spread a little bit more. So to make a progressive traction, and in this way you don't have any pain after.
And you never de-articulate the rib?
Never. Never. That's too traumatic in my opinion.
Yeah. Dr. Glauber, thank you very much for your time and for the talk. Thank you.
It was a pleasure.